Dr. Gauri, we have start. 1, 2, 3, start.
Okay, so a very good afternoon to one and all. I am Dr. Gauri Godse, a consultant dermatologist practicing in Navi Mumbai and Mahim. It is my pleasure to welcome you all on behalf of Navi Mumbai Doctors Foundation for our 145th CME on allergy. So I'll have the honor to introduce to you our renowned speaker for today, Dr. Sunita Shukla, who is an ENT surgeon, a renowned one, who is a founder director of the Mumbai Medical Center and an honorary consultant allergist at KEM and Global Hospital. She did her master's from Nayan Hospital and her advanced allergy training from Harvard Medical School and Boston Food Allergy Center. She has received many awards on a national and international platform due to her immense medical and academic work. So before I ask ma'am to start the session, a very quick announcement for our audience. I would request you all to keep your audio on mute and switch off the audio for smooth functioning of our session. Also feel free to leave down your questions, which we will answer by the end of the session. So I hand over to you, ma'am.
Good evening, everyone. Thank you, Gauri, for the kind introduction. At the outset, I would like to thank Dr. Kure and Navi Mumbai Association for giving me this opportunity to talk on this platform. So Navi Mumbai is very close to my heart because that is the place where I was brought up right from my childhood. And post-marriage, I shifted to Mumbai. So anything related to Navi Mumbai is my heart. So thanks, everyone. It's a pleasure to be here. So today I will be talking about allergy. And when I was discussing with Dr. Arun about how we will go, I said, let me discuss some interesting cases because in COVID, we all have heard so much of theory and so many of, webinars. So let us make it a nice interactive and interesting session by putting up some nice, interesting cases. So as we all know, allergy is an overreaction of the immune system to a substance that is harmless to most of the people. But this immune system can overreact, causing symptoms which can be irritating, affecting quality of life, and also sometimes life-threatening. So initially, allergy was known only to be a disease of the rich class. But now, as the technology is growing and how we are westernizing the hygiene, the food patterns, the eating habits, the culture, everything is changing. And now, even in India, we are seeing that these allergies have increased. So they not only affect the rich people, but also the middle class and the lower class people. And pollution adds to it. So the burden of allergic disease, if we see, the respiratory allergies are the most common. In respiratory allergies, we have the nose and the lungs. And that's why allergic rhinitis and allergic asthma form at least 30 to 40% of the people suffering from it. In kids also, it is almost the same. In allergic rhinitis, we know once an allergen which enters the nose, it can be in any form. Once it enters, it causes symptoms of nasal itching, sneezing, running nose, and blocked nose. So why does this happen? This is nothing but a defense of the body that once the allergen is in the nose, the body tries to filter it out there only and remove it from the nose. It does this by causing itching, which is due to the release of histamine. When you sneeze, because of the forceful blow, the allergen is thrown out. And due to the running nose, the allergen is tried to be washed out from the body. But if that doesn't happen, if the allergic cascade starts, we can have a itchy throat also and later on a blocked nose also. Similarly, when these allergens enter from the nose into the lungs, they can cause symptoms of asthma. Whatever today I'm talking about asthma is about allergic asthma only. We have lots of other phenotypes of asthma and that is not we are talking. Today it's only about allergic rhinitis and allergic asthma. So we all know when this allergen goes inside the lungs, it reaches the bronchioles and the alveoli, and there it causes a bronchospasm, leading to an inflamed airway and mucus secretion and all the symptoms of asthma. So very recently, World Allergy Organization renamed this as a one airway, one disease, because the nose and the lungs are not different. They are one system. They have anatomical continuity. They have same physiological function. And also the mediators of inflammation are also the same. And if we see, the treatment is also the same, that is mostly in the form of topical steroid. That's why now there is a concept of one airway, one disease, or a united airway disease. The pathogenesis of any allergy is twofold. First step of an allergic reaction is an allergic sensitization. Here, once the allergen enters into the body, it activates the mast cells and the plasma cells, and the Th2 system is activated, and all the allergen specific IgE antibodies are made. These IgE antibodies are now sitting on the mast cells. So now once in the next stage, when an allergen enters into the body, these allergen will attach to these specific IgE bodies on the mast cells, which causes degranulation of the mast cells. And once the mast cell degranulates, they release chemical substances like histamine, prostaglandin, leukotrienes, and so on. These then act on the end organs, depending whether it's the nose, lungs, skin, and they give rise to the various symptoms of allergy like itching, sneezing, running nose, wheals, and so on. So this is how a electron microscopic picture of a mast cell is seen. On the left side, we can see it is a mast cell with lot of IgE mediators. Now, once the allergen comes and sit on these IgE antibodies, the mast cell is activated and it releases all the chemical mediators. So in the early phase, we can see that histamine is the most important one, which is released. And that's why most of the time when we give a patient the antihistaminics, all the symptoms of histamines are reduced, like sneezing, itching, rhinorrhea, and so on. But it is the late phase allergic response, which happens after 4 to 5 hours, where the cytokines and the leukotrienes are increased. When they are released, it causes more of a blockage system. That's why in this stage, it is the steroids which are the mainstay of the treatment, whereas in the earlier stage, it is the antihistaminics. We know there are various ways in which the allergens can enter the body. It can be through a skin contact, through ingestion, that is a food allergy, through injection, which can be medication. But the most important are the inhalation. In inhalation, we have various types of allergens. We can classify it as a indoor allergen and outdoor allergen, which are very typical depending on the symptoms of the patient. And there is a mixed class which is present in both, like the fungus. We can find it at home also and outdoor also. Many times we have, if you see the patients, sometimes have a symptoms which is throughout the year, and that's why it is called as the perennial allergic rhinitis. And sometimes the symptoms are only during the season. Like this is a rainy season. Most of the time the patient will say, yes, their symptoms increase during the rains or during winters. So whenever it's a seasonal allergy, most of the time the culprit are pollens and some of the fungus. But in perennial allergic rhinitis, most of the time these are the house dust mite and the pets, which are indoor, cockroach and fungus. So this is a microscopic picture of a house dust mite. This is how they are seen. They are microscopic creature. They don't have eyes, and they cause 70% of the allergies throughout the world. This is a small clip of the dust mite. You can see they are transparent organism, and the white structure which we can see, which this dust mite is eating, is nothing but our human skin cells, which are shed whenever we sit on the bed, sofa, carpet, and so on. So this is how they feed. And it is most of the time they don't bite us, but it is their feces, their eggs, their body particles, which are actually very strong allergen. And that's why these allergies are seen when the patient is on the bed and in the inside of the house or the office. Contrary to the belief, when it is dust, the indoor dust is very different from the outdoor polluted dust. Both are very different. These are the pollens. This is a natural process of the nature has made so that the trees and the flower, they can pollinate. On the right corner, bottom side, we can see the cynodon, which is the common garden grass, which we see daily. This pollen is found throughout the year, and most of the time, if the patient has cynodon allergy, the symptoms will be throughout. But there are many pollens which are which have variation of during the season of the year. Now, whenever we take a history, we always take a second history also once we do the test to see whether the symptoms correlate or not. The other allergens which we can see are the fungus, and this fungus, most of the time people don't know, but in a place like Mumbai or small cities, we are very fond of having trees and plants in our balcony. And most of the time, these will have some amount of fungus, and we don't realize what is the cause of the allergen. Obviously, leaking walls and all those things can also have fungus, which can be easily repaired. Another notorious allergen in Mumbai is the pigeon, which is known to cause hypersensitivity pneumonitis. We know there are so many cases going on in the Bombay court because of this, and how they damage the lungs and cause ILD. That's a different issue, but these are also very notorious. If someone has pigeon or mold allergy, we have to realize that it's not only the house, even the AC will have these substances, these allergens. Even a car AC can be full of fungus. So some of the other indoor allergens are I'm getting some disturbance in the audio.
Yes, ma'am. Just
Yeah, thank you. So these are some of the other indoor allergens. The commonest are the pets. In housewife, we see the weevil, which you can see the rice weevil. These are the small black insects which are present in most of the grains. We can also have cockroach, bees, ants, etc. as an important allergen. Cockroach is one of the second most after dust mite to cause allergic rhinitis and asthma. In asthma, it's a very, very strong allergen. In pets, cat has a more strong allergenicity than a dog. And it is said that if you have a pet at home, which is a cat, and even if you remove the cat from the house, the allergen stays in the house for at least 9 months. So that is the allergenicity of a cat allergen. Some of the food allergens which we know are nuts, seafood, wheat. Gluten is a new myth nowadays in the market, milk, and many pulses. In India, the commonest pulses which we see is the chana dal or the besan. And after that is the seafood. So food allergy can cause various symptoms. It can give rise to respiratory symptoms. Obviously, gastro symptoms can be there like abdominal pain, vomiting, diarrhea. Many of the time, if the patient has food allergy, they can get urticaria, angioedema, hives, and so on. But if the patient has severe food allergy, the patient can also have a severe allergic reaction, which is called as anaphylactic shock. And in this, the patient can die also. Luckily, we as Indians don't have so much of food allergy, but in US, for example, the peanut allergy is so common that kids lose their life if they don't get treatment on time. But in Maharashtra, we have peanut everywhere around us. We have it in our breakfast like poha, we put it in dals, we put it in dessert, we have peanut chikki. So peanut is everywhere, but luckily we are not allergic to peanut. So this is I thought I will show food allergy can happen to anyone. This is Sonu Nigam. 2019, he got this attack to seafood allergy, and he tweeted that luckily he was close to Lilavati hospital. He got treatment on time. Otherwise, he would have asphyxiated due to stridor and breathlessness. So there is a difference between food allergy and food intolerance. Food allergy is a problem of the immune system, and here they can be fatal. That's the most important part. Whereas food intolerance is a problem of the digestive system. So patient will have, bloating, indigestion, stomach pain, nausea, vomiting, even diarrhea. Many of the IBS patient has diarrhea. So that is food intolerance. These are the few examples of skin allergy presenting as urticaria. These are the wheals. Urticaria itself is a very different topic, which I'm not covering, but if it is associated with food allergies or drug allergies, we can get a picture like this. We can even have angioedema presenting in this manner. You can see the lips and the eyes and the whole face is swollen. And this is another lip angioedema shown here. Many times we see that we get a lot of pediatric patients suffering from these allergies. So allergic marks is nothing but a series of events which happens in a kid, especially when the parents have allergies. So if one of the parent have any of the allergic genes, chances that the kid will have it is 20 to 30%. But if both the parents have allergies, chances of this kid having any one type of allergy is more than 50%. So the genetic tree is very important when we take the history. And usually in such kids, we'll see that the allergies start in the infancy period in the way of eczema. And as the kid progress, it can present as food allergy, it can present as rhinitis, asthma, or vice versa. So how it will manifest, no one knows. Many times rhinitis may precede asthma, or asthma can precede rhinitis. But it is seen that if the patient has rhinitis, 30 to 40% of them will have asthma. But if the patient is asthmatic, at least 70 to 80% will have allergic rhinitis. So that is the incidence which we see. And hence, to be aware that this is a spectrum, allergy is a systemic disease and it can has multiple symptoms, is something which we should keep in our mind. This is a very common allergy triangle which consists of allergic rhinitis, asthma, and eczema. One thing which I didn't put a slide is of the Samter's triad, where a patient can also have a NSAID sensitivity along with allergic rhinitis and nasal polyposis. So the diagnosis of IgE-mediated allergies are usually by two most important things. One is the skin test and other is a blood test. The skin test is called as the skin prick test, and it is the gold standard diagnostic method which is followed throughout the world. And the reason, this is a small clip of how do we do a skin prick test. Here we put a small drop of the allergen on the forearm or the back, and we do a very small micro prick with a needle. With this, there is a breach in the stratum corneum. The substance enters into the superficial layer of the skin, and there it causes a allergic cascade. The same thing which is shown in my previous slide, that how this allergen will get attached to the Ig bodies present on the mast cells. It will cause degranulation. And within 15 minutes, we get a wheel and flare reaction like this, which you can see on the left side. These are the dust mite allergens. The size is the severity. The bigger the size, the more pseudopodia it has, the more severe is the allergy. So contrary to the belief, skin prick test is a painless and a bloodless process. Here we can see that we can easily do it for the kids also. They don't even cry. You just have to talk into them. And within 15 minutes, we see the result. Whereas many times people ask that why blood test is not good. So in blood test, we see the circulating IgE, whereas in skin prick test, it is the actual allergen which goes and activates the mast cells. That's why throughout the world, skin prick test is a gold standard diagnostic method. It's very common to see that when patient comes to our center, he gets a food allergy test done to multiple of the food, like 200, 300 food and allergens are present. But there is a precaution in this. These food intolerance test is basically done for IgG and not IgE. And this is a slide about the European Allergy Task Force report, which states that the food-specific Ig does not indicate a food allergy or intolerance, but it just means that there is a response of the immune system after exposure to that food. So in a nutshell, what I mean to say is that for food allergy, don't ask the patient to get a IgG4 testing done. It should not be done for anything. It has no value. And many times we say that depending on these reports, the patient has asked to stop all the foods, which compromises on the nutrition of the patient and further decreases the immunity. So what should we do for a food intolerance? So we can have lactose intolerance, fructose intolerance, sucrose intolerance. For these, we do something called as the hydrogen breath test, where we ask the patient to drink a liquid, and every 15 minutes that he blows into a machine. And if there is a more of the hydrogen levels, the parts per million, then we diagnose it as a lactose intolerance or food intolerance, which can be treated very easily. So the treatment for any IgE-mediated disease are fourfold. Once you get to know what are the allergens, the most important thing is avoidance of that allergen. So this is very easily said and can be done for food when you can see that food. But most of the time when it is an aeroallergen, it's very difficult to advise the patient that you avoid dust mite. You can give avoidance measures so that when the patient cleans the house in the way which we say, the load of the dust mite will decrease, but you can't make it a zero dust mite area. Same thing for the pollen also. Once you go out, the pollens are microscopic, they are in the air. These plants pollinate through breeze, and wind helps it. So it's very difficult to avoid pollens. You can take measures like whenever you're going, you close the glass windows of your car, but total avoidance is not possible. So the most second important pillar comes is a medication or the pharmacotherapy. Most of the time, any allergic symptom the patient gets, we give them pharmacotherapy. Like most of the time, it's antihistaminics. For allergic rhinitis, we have nasal sprays, which are topical steroids. For asthma, we give inhalers in the form of pump. Again, the patients have a lot of myths about this pump. They are not happy that if you say you have asthma and please use the pump. But here we have to explain them that these are in micrograms. When you take a tablet, the tablet is a milligram tablet. But when you take these inhalers, it's a microgram dose, and it goes only into the lungs or the nose. Because it goes only there, it doesn't have any side effect. Whereas if you take an antihistaminic tablet, which we all know, like if you take a cetirizine or a Avil or any other Atrax, the patient sleeps. Next day, he is not very happy. He can't concentrate on his work. Quality of life is bad. And this is so important for kids, especially the school going kids. You'll see that their scholastic performance decreases. They don't like to go for outdoor games and so on. So those are the issues with antihistaminic and other tablets. The second generation antihistaminics are better. And most of the time, if it is urticaria and all, lots of time the patients are given steroids, oral steroids. That is one part of it. So the third important pillar is education of the patient. Once you know what is the allergy the patient is suffering from, you have to make the patient aware for that. So at my center, for one patient, we take at least 1 hour, because getting into the detail of the history, and once you get to know the allergens by a skin prick test, you educate the patient of how to avoid it. But many times we'll see that even after doing all these things, the patient doesn't become better. And then comes the fourth most important pillar of treatment, which is a allergen specific immunotherapy. So this allergen immunotherapy is a only disease modulating treatment present on this earth. Throughout the world, AIT is the treatment for any IG mediated allergies, because in this we go to the root cause of these allergies and we treat the root cause. Whereas when you give pharmacotherapy, you're treating only the symptoms. So there is no point of clipping the branches and the leaves of a tree. Go to the root level and treat the root level, which are the dust mites or pollens or whatever allergy. And when this immunotherapy, it can be given in two forms. This is the subcutaneous immunotherapy, which is also called as the allergy shots in US. And the other newer form is the sublingual immunotherapy, where we make the drops, and it's very easy to take it. Even kids take it at the comfort of their house. In the injection or the allergy shot, you have to visit the doctor's clinic every week. And after the shot, you have to wait there for 30 minutes so that if there is a reaction, it can be tackled. But post-COVID, slit has come largely into vogue. And the way it has changed the allergy treatment is superb. So many times patients ask me how exactly it works. So it is not a steroid, it is not a medicine. It is like when I tell them that you imagine your allergy is like a surgical strike. So it's a border, and suppose there is one allergen or one soldier comes into it, 100 of the other soldiers will attack. In this process, there will be a bloodshed. So this bloodshed you compare to histamine and other chemical reactors, and you get a reaction. But suppose you must have seen this movie. Suppose we send a spy to the enemy's house, where he will become friendly with them. He will talk to them, eat with them, sleep with them. And at night, when everyone is sleeping, he will kill the enemy, and then you become victorious. So this is the how immunotherapy works. Because we give it in a very slow, low concentration, it goes into the body, activates the TH system, and desensitize the body, or we develop a tolerance to that specific allergen. So that is how it works. that is the same principle for any vaccine, whether it is the COVID vaccine, the BCG, the polio drops, or so on. So the sublingual immunotherapy has been widely accepted throughout the world, and now it is gaining popularity. In India also, we are using it. It is present in US, Europe, and everywhere. And this is the World Allergy Organization's position paper, which was released in 209 and then 213 also. The advantages of immunotherapy is that it increases the quality of life, it decreases the symptoms, and that's why it decreases the medication requirement of the patient. And the way it changes the quality of life is the patient totally goes symptom free and medication free. But we never say it is 100%, because since there are so many allergens, we treat only 1 or 2 important allergens. And even that, if it gives 80 to 90% relief to the patient, it is superb. But many times it is not the nose or the lungs of the patient which come to us. When the patient comes to us, they have multiple allergies or overriding on each other. As I said, it could be a dust mite, pollen, mold, pet, fungus, food allergy, drug allergy. So these are the patients which have multiple drug allergy syndrome. Now we'll see that the IgE, which is the most important culprit in such patients, and whenever we do, the IgE is always high. So ideally, it should be between 30 to 100, the total Ig level. But we see in this patient, it is thousands. And I'm treating a kid who has a 25,000 Ig level. So because of, if we don't treat the IgE in severe cases of nasal polyps, asthma, and urticaria, it becomes very difficult. That is the time where the monoclonal antibody for IgE has come up, which is omalizumab. This is a game changer, and it has totally changed the way we practice allergy. So this is omalizumab. It is a humanized monoclonal antibodies against IgE. It binds to the freely circulating IgE and makes them inactive. So though they are present in the body, they are not available for the allergen to cause a reaction. Since the reaction doesn't happen, the mast cell doesn't degranulate, there is no release of histamine and other chemicals, and that's why the reaction doesn't happen. So this omalizumab, it binds to these FCER receptors and decreases its affinity, and thus it changes the whole pattern of the allergy cascade. This is how the dosing of omalizumab is done. This is for the nasal polyps, which I have shown here. So it depends on 2 factors, the level of the IgE and the weight of the patient, and accordingly the dose of omalizumab is decided. So omalizumab can be used in multiple IgE syndromes. Like at my place, we are using it for allergic rhinitis, nasal polyposis, in asthma, food allergy, eosinophilic gastroenteritis, in anaphylaxis. I will be showing few cases where we have used it, and it gives very good result, especially in urticaria. These are the few 2 cases of food-induced anaphylaxis. In this, she is a microbiologist from, she has egg allergy, and when she came, you can see how the eggs are so severe. And in such cases, we can't even give vaccines which have egg, because they can have anaphylaxis. This is a case of patient with a cashew nut anaphylaxis. That is how he presented to me. So we can see that this is atopic dermatitis. This is again a multiple allergy syndrome. But when I was treating her, nasal polyps with omalizumab, I saw a drastic result in her atopic dermatitis also. So this, I think, is a collateral benefit of given anti-IgE, which we never expected, but this is how it happens. So being a allergy talk, if I don't talk about drug allergy, it will be not right. And drug allergy is an enigma. It is like the work of a Sherlock Holmes. Who is the murderer? Most of the time, these patients who are admitted in the hospital, they are given a cocktail or multiple drugs, and we don't know what has caused the allergy. So I thought I will present 1 or 2 interesting cases, how this drug allergy present and how can we diagnose them. So this was a young female who had a history of allergic rhinitis and food allergy. In 2009, she had taken Norflox. She had some rashes which went away with taking antihistaminic. But in 2019, she took amoxiclav for URTI. She again developed the rashes. converted to azithromycin, tolerated well. Now this lady went to the dentist. She was supposed to undergo a RCT, and the doctor said, we'll be giving you Ciplox. That's the commonest drug given for any dental procedure. And then this patient said that I have allergies to Norflox, amoxiclav, and so on. So this patient was referred to me that can we give Ciplox to her? So when such a patient comes, we actually do a skin prick test and intradermal testing of that specific drug, and in a very in a low concentration, and we go on increasing the concentration. In this picture, you can see that with a 1:10 and 1:1, there is a big wheel and flare reaction. This is a typical of allergy. Now, this is a IgE mediated allergy to Ciplox. If we give a tablet or IV of Ciplox, this patient will definitely land up in a severe allergic reaction. So obviously it has to be avoided. Now it is proven beyond doubt. So the next question was, what is the alternative antibiotics? What can we give for the dental procedure? So after discussion with the dentist, we decided to go for ceftriaxone. This is the skin prick test and the IDT done for ceftriaxone, and the patient tolerated it well. Now, once the skin testing is negative, we have to do an oral challenge test with either tablets or the IV infusion. So here we tried cefixime, which was tolerated very well. And this person then underwent a RCT after taking under the cover of cefixime. So every drug has a different protocol. It is not one rule for all. And that's why it becomes very challenging. And it should be done at a center which has all the facilities where if the patient gets any reaction or anaphylaxis, you should be able to manage it very well. This is another case of a doctor who had asthma on ICS. There is a family history of allergic rhinitis. In October 2019, she took 1 dose of Levoflox, and this is how the rash, the lesion appeared. And this is typical of a fixed drug eruption. This is a common thing with the quinolones, and this is how it healed within a month. But the speciality of fixed drug eruption is that every time you take the offending drug, you will get the lesion at the same place only. So in October 2020, she had diarrhea and she just took, casually a dose of Ciplox TZ. She had already forgotten that she reacted to Levoflox. But within few hours of taking the Ciplox TZ, she developed the same rash over there with severe itching and redness as it can be seen. But luckily, there was no lesion because after that 1 dose, she stopped that medicine. And this is how it healed after a month with, desquamation. So this is typical of FDE. The only thing is for this, if we want to do a testing, it has to be done at these lesions only because the mast cells are located at these points and it can't be done on forearm or any other part of the body. So these are the few cases of drug allergy which we have done at our center. This again, you can see is the Ciplox. The inner blue lining is the way we inject the intradermal dose. And the red one, you can see the dark red is the wheal and the dotted red is the erythema around it. So this is a proven case of Ciplox allergy. This is a case of Magnex allergy. This is a lignocaine. This was a very interesting case. She is an old lady who was diagnosed with lignocaine allergy 20 years back when she was undergoing a ophthal surgery. Now, for 20 years, for any local procedure, they have avoided lignocaine. Now she went to the dentist. She had some issues, and the dentist said, "Okay, we can't give lignocaine." So she underwent a root canal without a anesthesia. So it's horrible to imagine how you can undergo such a RCT without a anesthesia. But then she was due for a second RCT. She came to us and we did the lignocaine skin testing. This was negative. Since this was negative, we went for a challenge with the subcutaneous dose where we increased the quantity as well as the concentration, and she tolerated it very well. And then she went and did the second RCT with the under local anesthesia of lignocaine. This is a very interesting case of a nurse. She was admitted in the ICU during the COVID wave, and she was given Avil for some rashes and she collapsed. And when we took this history and all, we thought it is a, Avil or a CPM anaphylaxis. So we did this testing and you can see that with a higher concentration, she got such a big wheal and flare. So this is the third case which we found in the literature, and this is undergoing a publication very soon. So this is avial allergy, though it is rare, we do see such cases. At a place when the COVID vaccine was introduced, unfortunately, our government said that if you have severe allergies, don't take the vaccine. So because of this, many doctors didn't take it, and we lost one of a very good colleague because she couldn't take the vaccine and she succumbed to COVID. So that was the time when we started doing the COVID vaccine component test. That time we were doing it with PEG and P80 because these are the components of most of the COVID vaccine. But now at KEM, we are doing a prospective study where we are doing the COVID vaccine testing with the help of these components and with the Covishield vaccine itself. So if you know of any patient who has not taken up the vaccine because of the allergies and because of the fear, you can send them to KEM. It will be done totally free of cost, and then they can take vaccine there under our supervision. So briefly about anaphylaxis, which is a form of severe allergic reaction. It can present to any part of the body, like it can present in the skin, the respiratory system with severe breathlessness, GI system, and the worst is the cardiovascular system where the BP drops and the patient can collapse. So in such cases, most of the time when the patient goes to the casualty, the patient is given Avil and hydrocot. But for any anaphylaxis, the most important treatment is epinephrine, the intramuscular epinephrine. So we know that we have adrenaline ampules 1:1000. Just take 0.3, 0.5 and inject it into the lateral border of the thigh. That is the treatment of any IG-mediated anaphylaxis. Avil and hydrocot can be given as supportive treatment for other for these ABCs also, but it is adrenaline which is the most important. If the patient becomes better, not completely, again one more shot can be given in next 15 minutes. So in uh, places other than India, we have a auto injector for adrenaline which is called as EpiPen, and so many others. But in India, we don't have it. We see so many patients of anaphylaxis who go and, they are not actually treated with adrenaline. So in India, we are very good with jugards. And how do we teach them? We give them an ampule of adrenaline. We give them a small syringe, 1 ml syringe, with like an insulin syringe or a tuberculin syringe. And we teach them that you keep this adrenaline with you all the time. In case you get an anaphylaxis, please inject yourself, or we try to teach their, close relative that how to do it. This is just so that by the time the patient reaches the hospital, he doesn't collapse and it is not a catastrophic event. So that was about adrenaline, which is very important. So with this, I conclude my talk. My take home message is that allergies can be diagnosed. Allergies are treatable and it can give you good quality of life. And the treatment for any anaphylaxis is adrenaline, adrenaline, and adrenaline. With this, I thank you for your patient listening. I'm open to questions, if any.
Thank you so much, ma'am. It was a wonderful session. I personally learned a lot because there is a lot of overlap in allergies when it comes to your and my field. So let's take the questions from our chat box. So the first question we got, what are the names of the allergen immunotherapies, oral and subcutaneous?
There is no name as such, but the immunotherapy, it is just called subcutaneous SCIT, that is subcutaneous immunotherapy, or SLIT, the sublingual immunotherapy. Now, the contents of the immunotherapy are different. It can be dust mite, pollens, fungus, and so on. So many cases we see, like suppose nasal polyps. There are so many nasal polyps which can be because of AFRS also, the allergic fungal rhinosinusitis. There it works wonders. A simple AR also, it works wonders. So there's no name as such, but the only thing is that there's so many people making it now that most of the time there's so much of mixing up, which is not a correct way. The less you give, the more effective it is. So that one thing has to be understood.
Okay. And also there's one more.
How many times?
Pardon?
Sorry. Someone is talking. I couldn't understand who.
Madam, what is the cost and duration of this immunotherapy? Sublingual or
Yeah.
subcutaneous?
So for the disease modulating effect, as per all the allergy organization of the world, it should be given for 3 to 5 years. Once you do it, the TH2 gets converted into a TH1 immunity, and that is how the patient doesn't get a reaction further. And the effect are lasting for 5 to 10 to 15 years. That's the best literature we have as of now. Now, the cost and all depends on what it is made, whether it is a subcutaneous one, sublingual one. There are many companies who provide it. There are people where technicians do the test. They order the immunotherapy from few places because they need a certificate for it. But at my place, I do the skin prick test myself and I make the immunotherapy myself. Because these allergens are made at different places. It has nothing but dust mite and pollens. The pollens are cultivated, the extract is then sterilized, and then that is the way it is made.
But sometimes this subcutaneous immunotherapy, itself can cause anaphylaxis. Is
Yeah,
it
that's
possible?
Yes, it is possible. That's what I said, that pre-COVID subcutaneous was given very rampantly, but now post-COVID it is slit, which is present everywhere, and it doesn't cause any reaction. And the slit, why it is good, because it enters the body the way allergens are entering. You give it in the sublingual area, that is the oral mucosa. So all the antigen presenting cells from there directly take it to the inner system, immune system. And that is the one drawback of subcutaneous one, is the allergic reaction. But if it is given in a very proper protocol, the chances of reaction is very less. But the person who is giving it should know the science behind it and the dosage and how to increase it. But yes, reactions can happen, though it is very rare. But one should know how to treat such reactions. That is the most important thing. Like in surgery, who is a good surgeon? Not the one who does a good surgery. But a good surgeon is the one who knows when to stop, and if there is a complication, how to deal with the complication. So same thing is true for allergy treatment also.
The duration is same for both?
Yeah, duration is same for both.
Is there any relation decreased platelets and drug allergy reactions?
No, not in decrease. See, in drug allergy, IgE is only one part of drug allergy, Ig mediated. There are so many other non-IgE mediated reactions, how drug allergy happens. That's the problem in drug allergy. Whatever we do for the skin testing, it is only for the IgE. We can't test any other type of drug allergy. But when we give a challenge test, drug provocation test, we only diagnose the IgE type, not the other types. That is the most, actually a loophole in drug allergy diagnosis and further treatment.
Madam, in one of the cases of streptomycin injection, 40-50 injections were given and subsequent injection caused anaphylaxis. How do you explain that?
No, it can happen. So if you see that the Ciplox allergy, which I showed, the doctor case, the second case with the FDE, she has taken Ciplox so many times in her life. But allergies can happen anytime to anyone, because somewhere the allergic gene is present. As we grow, the environment, the internal environment, the external, there's so many interactions happen. So allergies can happen to anyone at any time. No one knows why it has happened now, but it can happen. And she was a doctor. She is a doctor herself, taken Ciplox so many times.
In that case, is it advisable to give test dose before any injection like streptomycin and Panidura?
Yes. It is always better to give test dose. So test dose is nothing but a 1:1 concentration, the undiluted concentration. You can do a intradermal test. But what the difference in between a test dose and a skin testing for drug allergy is that the way we make the dilutions, and we very gradually give it. If there is no reaction in the the lower concentration, we go to the next highest concentration. No reaction there, we go to the next higher concentration. Every time we monitor the parameters of the patient. It's not that we just leave the patient. Every 15 minutes, we do this step, we monitor the basic parameters, then only we go ahead. So the time we see a reaction, we stop. That is the safety of the drug allergy testing. Like, we can't do it directly, just give a tablet and see. The patient can collapse also. This is avoided in a drug allergy test. So the protocol which we follow is of the Harvard School. That is where I learned my drug allergy, and every drug has a different protocol. That's why it is very challenging. Like even I have to do a drug testing, I have to go refer, see the protocols, make the dilutions. Not one rule for all the drug. That's the difficult part about it.
So in short, it is better for GPs not to give injection. They should refer to hospital or nursing home where all the facilities of resuscitation, adrenaline, oxygen, everything is available.
So this
Many
is
doctors are afraid to give injections.
no, this is true for patient who has a history of allergy and something like this has happened before. You can always do a test dose. So drug allergy thing has come now. We are realizing we have been practicing for ages. You are practicing for ages. We are practicing. We have been following the same protocol every time. So best is to give a test dose. Definitely, it won't cause an anaphylaxis, which a full dose will cause. So it's always better to do it. There's no need of every time referring to the hospital. If you all refer to hospital, kaise chalega? Load itna बढ़ जाएगा. You will be happy you do it at your center. So that's why that please do it at your OPD. See if there is something, and then you refer. Sir.
Okay, ma'am. Someone has asked how many foods can be tested at one time in the skin prick test?
So the most important are 8 foods, which are called as the big 8. You can see now, the more expert you are testing the size decreases actually. So when we started, we used to do 150, but now I do only 70 or 80 total allergens. I'm not talking about food. So depending, ऐसे तो if you see na, people will do 200 food also, उसमें तेल मसाला सब आ जाता है. But that is not how it is done. We have to understand that these IgE are for basically proteins. We have seen fake reports of fake lab. They will do it to cement, talcum powder. I'm sure Gauri must have also seen all these reports.
Yes.
But that is not actual allergy testing. That is not the way it is done. So, and how I feel is that suppose I am a novice shooter, if I want to shoot something, I will take a AK-47. I will do dhad. Ek to goli nishane pe lag jayegi. But if I am a sniper, I just need one bullet and one revolver, and I know how to shoot it at the right place. It will be a bullseye. Same thing happens in allergy practice. The more experience you are, there is no point of doing all this testing. When you take a history, depending on the history, my allergen list will come down. It may be only 10, it may be only 20. In kids, we do very few allergens. Like someone of 5 years coming with the early morning sneezing, I will just do dust mite for him. I will not do anything else. So that history taking is very important. And then you decide how to do the allergen. So in this, one rule applies to all is not true.
Ma'am,
Okay.
my daughter's total IG levels came around to more than 2000. So she was advised immunotherapy. So can this sublingual won't do for her or what?
So, madam, it depends what allergy she has. See, based on the total IG level, you don't give immunotherapy. Okay. When you do a skin prick, that's why I said a skin prick test throughout the world is the gold standard diagnosis. Whether she has allergic rhinitis, asthma, which type of allergy she has, that is one thing. IgE should be correlated with the symptoms of the patient, and then only you give a anti-IgE, omalizumab. You should not directly give. And if you give immunotherapy, it doesn't affect the IG level. Immunotherapy will give her, desensitize her only to those specific allergens, nothing else. IG is a total thing. आप IG के लिए कुछ करो नहीं करो, that is a body's system. The body has learned over so many years. Like I showed you the surgical strike. हमको पता है हमारा border पे हमको soldiers चाहिए, तो आप वहाँ पे अभी थोड़ा सा भी खतरा हुआ तो 100 के बदले आपने 1000 soldiers उधर रख दिए. Same thing the body does. The time the allergens start entering the body will start making all these IgE, so that it's a defense mechanism. ये अगर if you are 30-year-old, 20-year-old, the body is doing it right from the childhood. 20 years से body IG बना रही, the body is not going to stop it. That is the way it is. We can't stop that. But yes, we can decrease the reactions of this IgE mediated things. That is how it works. So it depends what allergy she has. You treat that allergy, and then the IgE over a period of time, in 2-3 years, 5 years, it goes down when you treat the allergy. बिकॉज जब एलर्जेंस ही नहीं जा रहे तो बॉडी अपने आप धीरे धीरे आईजी बनाना बंद कर देती है.
Okay, ma'am. So we have another question. So if the patient says that he is allergic to lignocaine, can it be confirmed?
Yeah, that is what I showed in my one case, na, that lignocaine allergy. The lady
Yeah, she did the
who had a
RCT.
root
Yeah.
canal, one she
I have one question.
and then we diagnosed it, and when it was negative, we went with the provocation test of subcutaneous dose. Initially I did a 1%, then I went to 2%. She tolerated everything well, and then obviously then it is not an allergy when you have done all this testing. She underwent a root canal with the lignocaine then, so it is proven that she doesn't have. See, in drug allergy the problem is mislabeling is very common. We have to understand a drug allergy is different, and the reaction, the side effects of a drug is very different. Many times a simple nausea, vomiting is given a name of drug allergy. Allergy, you know, allergy is such a common word. सब कोई सब चीज के लिए एलर्जी वर्ड यूज कर देते हैं. सो ड्रग्स तो आर द वेरी कॉमनेस्ट कल्प्रिट. कुछ भी हुआ मुझे ड्रग एलर्जी है. सो एक्चुअली इट इज नॉट एलर्जी, इट कुड बी अ साइड इफेक्ट. It could be just, you know, gastritis, which the patient says as allergy. So we have to take a detailed history, understand the symptoms, correlate with the timings, whether there is a temporal spatial relationship, what was it, how was it, and it should happen every time the patient takes the drug. Once he is taking, nothing happens. Second time it happens, it doesn't happen that way. It will be always there. So you have to understand what the patient is saying and then could come to a conclusion whether it is a drug allergy or not.
True. Right.
Excuse me,
And
it just
Dr. Sushma. Hello.
hello.
Can I ask one question?
Yes, yes,
Hello?
please. Dr. Sushma, yes, you may go ahead.
Yeah. Ma'am, I wanted to ask you, which immunotherapy is better in results, like sublingual or subcutaneous? Which one is better to give the faster results? As I am myself, I'm a pathologist, but I myself have allergic asthma. So I'm now I'm getting sublingual immunotherapy, but I have a curiosity that what is subcutaneous immunotherapy like?
No, so
The
subcutaneous
contents
is
are same.
So subcutaneous is as efficacious as sublingual. There is no difference in any of them. But the only problem is for subcutaneous, every time you have to go to the doctor every week or maybe twice a week, because once he will give you 0.1 ml. The next week he will give you 0.2 ml, then 0.3. That is how the dose is increased. That's why you get desensitized. This doesn't happen in sublingual. Sublingual may you take your stuff, you take it yourself every day in the morning. You are not dependent on anyone. You don't have to take leave from your work. There's no chances of reaction also. And that's why it is so good in kids. If a kid can take, an adult can easily take that, therapy. So I love sublingual immunotherapy. If I have suppose 800 patients now of sublingual, I have only 4 patients of skit subcutaneous, but that was pre-COVID. Now they have also shifted to sublingual. And I don't see any advantage of subcutaneous over sublingual. No advantage at all.
And what is
How many doses of
omalizumab?
omalizumab needed, madam? At what interval and what is the cost of omalizumab?
So, sir, omalizumab, I showed that one chart. It depends on the condition. Like for allergic rhinitis, for polyps, the dose is different. For urticaria, the dose is different. Now, for urticaria, it is 300 milligram every 2 to 4 weeks. That is a standard one. But in polyps, you have to see the weight of the patient and the IgE level of the patient, and then you give accordingly. In urticaria, it can be given every 2 to 4 weeks, irrespective of a normal IgE level. That is the most important thing. People think, okay, IgE level normal hai, so don't give. In urticaria, IgE level has no value. It's only in polyps and asthma that IgE level has some value. And we need an IgE test for that. But in urticaria, you can just give it. Now, coming to the cost, you asked me. So there is only actually one original brand of omalizumab by the name of Xolair, which is made by Novartis. That comes in a 150 milligram ka vial or a pre-filled syringe. Cost of that is some 32,000, very costly. But as I said, we Indians are very good at jugaad and we come up with a very good solution always. So we have made a similar, Reliance has it, marketed by Cipla also. So that comes at around 10,000 and 13,000. So efficacy of that is also good. Hardly 5-10% difference. We are giving both at our center, and I find very good results with both of them. So now, depending on the patient's affordability, how the patient is doing, it can be given. Only one thing is that the patient feels that if you have given omalizumab, the Ig level will come down. That doesn't happen. You have to tell the patient that, see, once you have given one Ig will bind to the omalizumab. So actually it will double. But so if you do a IG after giving omalizumab, it will be 2 or 3 times. So the patient will say, well, agar aapne galti se bol diya, chalo IG wapas kar lete hain. The patient will come to you, see, you gave me injection and the IG has increased. So we have to tell them that Ig levels are not done for 1 year after giving omalizumab, because now they both have binded together and the levels will be high. But this IgE is now an inactive form. Though it is present in the body, it can't cause allergies. And so please don't do a IgE level again. So this we explain our patients. Otherwise, so it will be havoc for us if such patient comes back. But the results of omalizumab is wonderful. We have other monoclonal antibodies also, like benralizumab, but all those are for asthma. So I didn't go into it because that becomes a very narrow part of the allergy practice. So for this talk, I didn't mention those things. I did only for omalizumab, because that is anti-IgE, which is the commonest cause of most of the allergies.
What about Allegra in the case of urticaria, chronic urticaria versus omalizumab? So can we use Allegra for longer time?
So if you see the guidelines, like suppose the European guidelines for treatment of urticaria, so it's a pyramid. So base of the pyramid is that you give antihistaminic. So you give the usual dose, OD or BD. If it is controlled, good. If it is not controlled, the second step is to increase the antihistaminic. So you can increase to 2 to 4 times. But it's very easy to say that you increase antihistaminic 2 to 4 times. You imagine a patient taking 2 cetirizine at night. With 1 cetirizine, you get so much of, sleepiness and dryness of throat that you have to wake up to drink water. What 2 or 4 cetirizine will do? Whatever said, it's not practical. The third step is a IgE, anti-monoclonal antibody. If the patient doesn't become better with that, then you go for immunosuppressants like the cyclosporine. I think that's what, Gauri, we all skin people are doing. But I have seen that in my practice, I have given cyclosporine. I have not given, but my the colleague has given only to 1% with omalizumab, because this is a kid who has a IgE level of 25,000. Multiple allergies he has anaphylaxis. So so such cases are very different. But most of the time, urticaria, you give all the options to the patient. When a patient comes to us, they have already burnt out all the options. They have taken Allegra, they have taken cetirizine, they have taken bilastine, everything they have taken. And when they come, it's like, we are tired of taking tablets. We don't want tablets anymore now. That is the time when the third step of giving omalizumab comes in. You have to see the quality of life also, what the patient wants. We give them everything on the platter. It's for them to choose. Many times they say that we are okay with taking tablets every day. So it's their wish. Give them the option. Whether they want tablet, they don't want. So depending on the age of the patient, the work practice of the patient, the work of the patient, everything, the patient, then that is how we decide what is the best treatment for them.
Yes, ma'am. True. Ma'am, we take a question from the chat box. Someone has asked if there's a known patient who has a history of SJS, like Steven-Johnson syndrome. Should a skin prick test be done prior to taking vaccine, especially COVID vaccine? Like,
no, so best is to go for a COVID vaccine skin prick test, the way we are doing it. So most of the time, drug allergies will not cause any issues. But suppose the patient has, what happened in our case in India, the government came with the rule that if you have severe allergies, don't take it. But literature says, and whatever studies we have published, like we have also published some article in JAPI, what is the role of allergy, and this we have a 257 study which we had done at our place. If you want, I can share it on the group. There is hardly any reaction to the vaccine. What people are talking, what people are seeing, that is another type of reaction. That's not an Ig mediated reaction. It can happen to anything. These patients are comorbid patients. They have multiple issues. Many times if the asthma is not controlled, chances of anaphylaxis becomes high. So this is not a contraindication to give. A SJS patient can take a vaccine, but it will be always better that get yourself tested first. We are doing it free of cost at KEM hospital. Let the patient come there. We will do it. And if there is nothing, let the patient take the vaccine. Because we have to understand that the benefits of taking vaccine is far, far, far more than the side effect of the vaccine. So that is what we have to explain to the patient. That's why, we have to talk to the patient, counsel, tell them the science behind it. Then they understand it very well, actually.
Yeah, right. Someone has raised hand in the participants. Dr. Mangala. Ma'am, you wish to ask something? Or maybe, okay, so we take another question from.
Hello.
Yes.
Hello.
Hello.
In a symptomatic patient.
Hello.
Yes, Dr. Mangala, you may speak.
NSAID allergy we have seen with lots of urticaria and even asthmatic or anaphylactic shock also. But is a generalized edema coming after one tablet? And it goes off after you stop the medicine if you're not taking it. That is also a type of allergy?
Yes, it could be. So in such patient, we'll take a detailed history, we'll do the testing. And if possible, then we have to avoid NSAID in such patients. Because the problem is a simple angioedema. When it can develop into a severe allergic reaction, no one can predict. Maybe this time it is mild, but the next time it can be severe. And the worst part is when it is the swelling of the tongue and the larynx. So when the patient says, my voice became hoarse, hoarseness of voice means that there is a glottic edema near the vocal cord. And if that edema increases, the patient will immediately go into stridor and, it can be a very catastrophic event. We don't want that. So any such symptoms the patient say, we should immediately understand it, diagnose it, and then accordingly give advice to the patient.
After some years, like now 25 years or 30 years, it can be started again or given like.
Better to do a testing and then start. That is what was the first case of Ciplox allergy. He had the first reaction in 2009. And this, when he came, that was 2019. So what happens, I will tell you, in penicillin allergy, the chances that after 10 years, the patient will outgrow that allergy is very high in penicillin or the beta-lactam group. But in allergies like for Ciplox and all, it is difficult. Cephalosporin, it is difficult. So we don't know how the body will react. Many times the drug allergies have cross reactivity also. So keeping all those things in mind, we have to advise the patient. But it's always better that you do a testing and then you ask the patient to take the drug.
NSAID, what test? Which test will you do? Which drug?
So when we ask the patient, we take the complete history, understand which NSAID has caused the problem. Okay. According to the protocol, we'll test it and then we will advise.
Okay, thank you very much.
Same thing happened in the lignocaine allergy also. No? She was diagnosed 20 years back. She had some eye surgery. For 20 years, she was avoiding it. It is, means doing a RCT without lignocaine, like it sends a chill down my spine. So I don't know how that lady tolerated. She's from West Bengal, political science teacher. Just imagine what she must have gone through. So she was like, I don't want a second RCT, please give me GA. But then someone referred, we saw it and everything was fine. So, that is how we have to. That's why that mislabeling is so bad.
I myself have avoided NSAID now from 25 years. 25
You're most
years.
welcome. You're most welcome to my center, madam.
Sure. Thank you very much. Thanks.
So, ma'am, yes, sir.
Can you hear?
Yes, sir. Go ahead.
In a symptomatic patient, if we do the total IG and if it is normal, does it mean that there is no allergy?
No, so symptomatic patient means what, sir?
You diagnose clinically allergic rhinitis.
No, so sir, the total IG, if you see the literature, total IgE has no value in diagnosing allergy or in treating a patient like allergic rhinitis. So if someone comes to me which doesn't have a severe form of allergy, it is not affecting the quality of life, I actually don't ask for total IgE. When do we ask for total IgE is when it is a severe form of the disease. affecting the quality. Like suppose in asthma, the patient has to be regularly on oral steroids. Still, the patient is not getting benefited. He is waking up most of the time at night with a wheezing. I have not shown a case here because these all things will be on the YouTube. So I couldn't show one or two videos, which was very good for explaining this part which you have asked. But in such cases, we do ask for a total IG, and then that is only for the decision of giving anti-IgE monoclonal antibody. Otherwise, we don't ask for a total IgE. It has no value in diagnosing any allergies. But yes, if it is high, it does give you a mirror that something is there, because it is not activated only in allergies. There are many other conditions where IgE is raised. So we have to go through the total testing of the body, the other symptoms, other diseases a patient has.
So the diagnosis of allergic rhinitis is mainly clinical?
Yeah, it is clinical. So I didn't show the area guidelines here. If you want, I can share it on the group. It is a clinical diagnosis. 85% of the times, or 85 to 90%, all allergies can be diagnosed clinically with history only. It is only when we know what are the allergens, so that you give them a specific allergen immunotherapy, you need to do a skin prick test. And so that you can give them the specific answer that this is the one which is causing, so you do this. Otherwise, sir, giving antihistaminic nasal spray, so everyone can do, which we are doing for so many years. As I am an ENT surgeon. I came into allergy because there was no answer to my question, the patient's question that, madam, for how long should I use antihistaminic? Till when should I use the nasal spray? With these questions, I started getting into allergy. And then when I saw what all drastic results it gives and the way quality of life of the patient increases, I went into allergy practice.
Thank you.
Thank you, sir.
And then which is better, omalizumab anti-IgE monoclonal antibody treatment or immunotherapy? Which is the better
both
option?
are totally different. Both are totally different. Allergen immunotherapy is the answer for any IG-mediated allergies, especially respiratory. If you see the evidence-based medicine for allergic rhinitis, it has a level 1A evidence. That means it works wonders. So maybe in one more talk later, I can go into the advanced, what are the new guidelines which ARIA has given, GINA has given, EPOS has given, and what are the correlation clinically with cases, I can present that. But when you give AIT, it works on the T cell immunity level. We are fooling the T cell, and the TH2 gets converted into TH1. Omalizumab, but this is a slow process. When you start giving it, patients start seeing the result in the 2nd month, 3rd month, and 6 months. When you give omalizumab, since you have made the IgE inactive, the patient sees a sudden improvement in the symptoms. So suppose I have a patient who has severe asthma, which is not controlled, and he is on regular OCS, oral corticosteroids, inhalers, and still he's getting issues. I will give omalizumab for interim relief, but my main course of treatment will be allergen immunotherapy, because that is the one which will change the whole course of the disease. Omalizumab, I will give 2-3 injections. Symptoms come ho gaye, so by the time my immunotherapy is taken, all the effect already. In nose, the effect is so good that the nasal sprays can be stopped within a month. 95% of my allergic rhinitis patient, I stopped the spray in 1 month after starting allergen immunotherapy, because the response is so good. This doesn't apply exactly in the same way to asthma, because it depends on what level the lungs are involved, what is the FEV1, what is the reversibility ratio. It all changes the whole scenario. But there, you have, like, if it is a eosinophilic asthma, you can give other type of this monoclonal antibodies also, like benralizumab, which is there in the market. But that will help only in asthma. If the patient has high IgE, he has AR also, he has urticaria also, then I will prefer omalizumab. So you have to see the whole spectrum of the disease. As I said, it's not the nose which walks. A patient walks in the clinic. A patient can have a nose allergy, lungs allergy, skin allergy, so many things. So looking at that picture, you come to a customized treatment. And no two patients will have the same treatment. It is different depending on what allergies you have, what allergens come positive, your IgE level, and so many other factors.
Yeah. Okay. Thank you.
Gauri, can I have some comments?
Yes, sir, please.
Dr. Sunita, fantastic presentation.
Thank you,
This
sir.
is been attended by almost 50 very high patient fall general practitioners, not only from Navi Mumbai, but from Pune, Thane, Dombivli, and Raigad part of it. You have done a great job.
Thank you, sir.
Your articles of JAPI I have read because I am one of the referees in JAPI and I am on the editorial board. They are
Thank
very
you.
useful. Now I got few rapid fires for
Yes,
the
sir.
benefit of the audience.
Okay, sir.
Which is the least sedative antihistaminic by your advice?
So
Experience.
one is Bilastine, second is Fexofenadine.
Okay, because these are the drugs which can be given to people who are in a high risk, like
Yes.
drivers and other
yes.
things.
Yes. So Fexofenadine
Right.
and is allowed by for the flight pilots also. So it
Okay.
is non-sedative. Same
Hmm.
thing is true for Bilastine because Bilastine is given early in the morning in an empty stomach. So we can give it to people who go to work and even to kids. It has very good results. But if it is itching or something where the patient can't sleep at night, that is the only time when we go for cetirizine because cetirizine has a stronger effect as compared to Fexofenadine.
Okay.
That's my
With which,
personal experience. Yeah.
with which antihistaminics your patient has slept for more than 48, 72 hours?
I have not given such antihistaminics to my patients.
Because I remember one person getting a PCAV injection and not waking up for 48 hours.
Yes, sir. Yes, sir.
What
Absolutely.
is your role on H2 antagonist in treating acute urticaria like ranitidine
Yeah.
or famotidine?
Yes. So there is a role of H2 blockers, and that is can be given into the like Rantac. What we talk is 150 to 300 milligram, but it is an add-on therapy. It is not the main course of therapy. So with H1, H2 can be also given, but it has very limited data. And to be very frank, sir, when the patient comes, that H2 actually doesn't work.
Okay.
So always the
nasal-
H1 increased doses.
The nasal steroids, ideally without immunotherapy, how much of duration you will advise? Or year long or depending upon the season?
So, sir, it can be given for a long term. There is no side effects of this. This is what we were doing in allergic rhinitis. And when there was no answer, this allergy practice happened. But the problem is taking nasal steroid every day is not a good thing. And when the patient says, I don't want to take it anymore, I want a permanent solution, that is where the allergy treatment or immunotherapy comes into. Otherwise, it can be given for a long-term benefit also.
I'll just recall to share some of the things. I am a MBBS of 1974 batch, and that time there was autohemotherapy which was practiced. Means you take out 5 cc blood and then inject into the nasal terminates. You know, since then the era of omalizumab, it is a quite change. One question about your omalizumab, that does it invite infections?
No, sir. If it is given properly, why any infection it should be given in a very nice sterile way. It's a very small injection. It's a 1.3 ml only, not more than that. It comes in a sterile way. And
no, I'm not talking about the local infection in general. Proneness for the infection which is increased with all the monoclonal antibiotics.
The commonest side effects of omalizumab is like something like a feverish feeling, arthalgia, weakness, and so on. I have more than 200 patients whom I have given omalizumab or the biosimilar. Only one patient got arthalgia. She was a young girl doing MBBS from Russia, and she was the only one who reacted to it. Otherwise, touchwood, I don't have seen any of these things as of now.
Thanks for proving the uselessness of IgE evaluation in urticaria. And what you said about
sir. That's a literature.
Increase in IgE levels. That reminds me of that Jerisch-Eczema reaction, which we might have studied in our second MBBS while treating syphilis and other things. So thank you very much. And I'm going to share your JAPI articles with all the group people. Very common advice to all of the private family physicians: always carry Lorfast Meltabs with you, because that is one drug which can be given sublingual and it acts very fast. And it can be useful for urticaria, sometimes in case of any allergies. So let us be in touch. Please share all your newer articles with us, and whatever is practically possible, that will be really appreciated. And Gauri has done a wonderful job. Gauri is the second generation of Navi Mumbai Doctors Foundation, and we are marching towards 150th CME. This CME had attendance of more than 50+, and all credit goes to you. Fantastic presentation. Thank you very much. Please be in touch.
Thank you, sir. Thanks a lot.
Over
Thank you,
to you,
everyone.
Gauri. Yeah.
Thank you so much, sir. That rapid fire of questions was very helpful and very quick. Ma'am, your presentation was very insightful. It was very helpful for all of us. It helped us resolve many of our common doubts. Ma'am, one last question, if you don't mind, from my side.
No, not at all. Tell me.
Post-vaccine, post-COVID vaccine, how have you been finding the incidence of new allergies or cases of rhinitis or asthma?
No, new allergies I have not seen
No,
any.
or pre-existing cases, once they take the vaccine, has there been any exacerbation or?
No.
Okay.
So that JAPI article, it has around some 250 patients. In them, nothing was there. And at KM, we have already done around 90 patients as of now, where we have done the testing and then maybe given them vaccine. The data is
Hello, ma'am. There's some connection problem. Dr. Sunita, can you hear me?
I think we have, yeah. Yes.
Okay, yes, ma'am.
so, as I said that in our initial JAPI article, it is more than 250 patients. In those patients, we have not seen. We have more than 90 patients at KM where we are testing. We have already tested them. None of the patient has complained of this thing that are such allergies have increased.
Okay.
So according to me, not.
Okay, ma'am. So, are there any more questions? I think we've answered all the questions. So there's one question which says, in paracetamol allergy, what should be given in case the patient has fever? And if the patient documents allergy to paracetamol? Oh. Ma'am, I can't hear you. I think you've been muted.
No, I am okay.
Okay, yeah, now I hear your voice now.
I think same, yeah, some.
There was some disturbance, yeah.
Anyway.
Okay, ma'am. So I thank you a lot for today's presentation and our session. On behalf of NMDF, it was an honor to have you. We learned many new things, and we hope you're there for us when we have few doubts or few queries more to ask.
Thank you, Gauri. The pleasure was mine. As I said, anything related to Navi Mumbai is close to my heart. So maybe we will meet in person very soon.
Yes, ma'am. Definitely soon.
And we can go to some advanced level of discussion with all the newer things coming up. This was very basic.